Thank you so much. So I was hoping to have a bit of a conversation with Emma. So it'd probably be a good idea to introduce her as well, as I'm sure she'll have a few words to share.
Then I shall too. And I'm delighted to introduce Emma, who's with us again. She's a haematology consultant to the Whittington Hospitals and University College Hospitals. Her PhD was based on research into markers of severity and predictors of organ dysfunction in sickle cell disease. She's North Central London and East Anglia HCC lead for sickle cell, and the North Central West London and East Anglia HCC lead for thalassemia and rare anemias. And her specialist interests are sickle cell disease and thalassemia and hemochromatosis. So welcome, Emma and Rachel. So we have a lovely double act, and then we're going to have a triple act at some point. So welcome. The screen is yours.
Excellent.
Both of you.
Thank you very much. Following on from what Joyce has just shared, I thought it'd be useful to share a real life example of a woman going through this sort of situation. So I'm going to give you a history of one of our ladies who I can start off by bookending to say she's very happily had a healthy daughter and who's about 1 year old actually at the moment. So all's well that ended well. But her story began, she got married to a British Nigerian chap about 6 years ago. She lived in Nigeria at the time. And because Nigeria has the highest concentration of sickle patients, it is not an unusual thing that people verbalize to each other, do you have sickle, or is there sickle in your family when you're getting married? So they'd had this conversation and neither of them had any immediate family members with sickle. Now she knew she had sickle trait, which is what she told her husband to be. So they got married, moved to the UK, settled down. A couple of years in, she gets pregnant with her first baby, and as per standard screening antenatally here, she discovers to her surprise she doesn't have sickle trait, she has sickle cell disease. What she has is the SC type of sickle. So she had been told at screening in Nigeria that she had sickle trait, but it's not uncommon that we have people who think they have trait arrive here and get screened and find out actually they have condition, just mild condition. So suddenly this throws a spanner in the works. So first of all, her partner has to be screened, which means she obviously has to go home and tell him what she's discovered. I mean, she should do that anyway, but she has to because he has to be screened. It did not go down well at all. He was convinced she had deceived him, that she knew she had sickle and just hadn't told him. They had a fairly horrific few weeks. Anyway, eventually he agrees to be tested, although as far as he's concerned, he has no family history of sickle. He's HbAA, so this is all just semantics. He has his testing and he has sickle trait. So suddenly they're faced with another conundrum. Now, do you want to get the baby screened? Obviously, time is moving on while all of this is happening. So she's coming up to, I think, 16, 18 weeks at this point, and they're having the conversations about, do you want to test to find out what your baby's going to have? Because he is absolutely adamant he doesn't want to have a sickle baby. She's already distressed about this whole, she's got a new diagnosis. She's trying to convince her partner that actually, I didn't know, I'm finding out at the same time as you. So she's dealing with all of that and then having to make decisions about whether she wants to find out what her baby's condition is and what is she going to do with that information. It was a fairly horrific few weeks. And then unfortunately for her, when she got to about 22 weeks, decisions are made, lots and lots of arguments, she miscarried. Which I think it was all a bit horrific, and she needed a lot of counseling afterwards, because I think part of her feared that she had willed the miscarriage to happen. It was quite horrific. Anyway, so fast forward a year, and they together, marriage is fairly healed with some simmering emotions underneath, one would imagine, but they're making decisions about the next baby. So the husband's absolutely adamant they're going to have PIGD, which is pre-implantation genetic diagnosis. It's essentially IVF with selected embryos. So they don't have a child with condition. So we refer them for this, they're entitled to it, they're going through the workup for it, and she falls pregnant without PIGD. So the question comes up again. What are you going to do? Are we going to screen this baby? Do you want to test it to find out what the status of the baby is? Do you want to just carry it through and then find out at the end? There's a bunch of options you go through. At this point, she's now had a couple of years, I think about 18 months, almost 2 years, to come to terms with her sickle diagnosis. She's fine with her sickle diagnosis. She envisages she's going to be fine having a child with sickle. Her husband doesn't want to have a child with sickle. So she then goes through the rest of her pregnancy with her husband, being quite clear that he doesn't want to have a sickle baby. So if they have a sickle baby, they're going to give it up for adoption. Oh. She just keeps nodding along, going, okay. But then telling her clinical team, now I'm keeping this baby, come what come may. It was fairly horror. It was fairly horror. Anyway, at the end of it, they had an AS baby. She's home, baby's fine, all is well. But that's an example of the sort of complexity these women can sometimes go through, because of course the difficulty for her, as Joyce will well know, is it's not simply just dealing with her husband, because African marriages are not simply just a husband and a wife, it's two families. So there's a lot of recrimination that goes back to her family. There's a lot of recrimination she faces from his family, and his family's here, hers is back in Nigeria. It was fairly awful. And Emma and I trained together, and we had a similar situation where someone who didn't know they were straight had a husband who obviously was straight as well. He also didn't know he was straight, so neither has family history of sickle. And then she gets pregnant, finds out she's straight, but they're not that bothered because he's not going to be straight. He doesn't want to be tested for whatever reasons. I can't quite remember. Probably needle phobia is probably the most common one. They have a baby who has sickle, and he walked out on her. Do you remember? We were renters when that happened.
Yeah. He left her, and the fact, yeah. And but then the other thing can happen, because I remember another patient who we both looked after, who was in a relationship with a chap, getting serious, thinking about starting a family, and I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was straight. This was one of our patients who had sickle cell disease, and she dumped him in the room.
Yes, she did.
Dumped him in the room in front of us.
Yes, I remember that.
And it was, but she had severe sickle cell. She knew, and she was very clear with him before he was tested that if he had traits, that was game over, and she was always very clear about the fact that, sickle cell had a massive impact on her life, in a really negative way. She spent months and months in hospital. She was quite small, she hadn't grown properly, had, again, very complex family situation, due to stigma in the family around her diagnosis, from her first degree relatives, from her mum, from her siblings, and she didn't want that for her child. That was her decision. And I think it's interesting because your lady Rachel had obviously quite mild disease because she didn't know she had sickle at all. So
she didn't, which is why for her the thought of having a child with sickle cell, well, she just thought, if sickle cell can be my experience, why can't I have a child with sickle? Although she was made aware that the experience is across a breadth, and you can't predict even with the same genotype. It is, I mean, pregnancy in sickle is, apart from the actual managing the pregnancy itself, the complexities of genetic counseling, the complexities of, what do you do with the results? A lot of sickle mothers are highly religious as well. So as Joyce pointed out, even talking them through, do you want to go through PND? Do you want to have the diagnosis? That has a risk of miscarriage. And for some people, that's unacceptable. For some people, they will go through the PND to find out what their baby status is, but they're not going to terminate. It is not, it's not even a factor for them. But for the partner, it might be, well, in that case, I'm walking. It sometimes can be so awful and difficult.
Because in thalassemia, it's slightly more straightforward in a way, because our patients are either transfusion dependent or they're not transfusion dependent. And that's mainly based around the change in the gene that comes from the mum and dad. And the case I was going to say was of a lady who actually doesn't have thalassemia. I first met her because she's the sister of one of my patients who does have transfusion dependent thalassemia. And this boy is one of my more complicated patients. He's had variable compliance with his medications over the years, i.e. not much, and actually has ended up, you know, twice in the relatively short time that I've been a consultant, 5 years, with very, very severe iron loading in the heart. And if you remember the last talk, that's one of the things that happens if obviously people are transfused regularly. They build up their iron levels if they don't take their chelation medicine. You know, this chap's, you know, is a very charming boy, but he's never really taken his medications. And he actually had a very severe level of iron in the heart, the highest level of iron in the heart that has been seen at either of my centres in the last 10 years. But his sister was brilliant. You know, she would, you know, when he didn't turn up for things, we'd phone her and she'd drag him along, and, you know, has been really important in getting him to comply. And actually his compliance has been a lot better recently, and this is possibly why. So she had thalassemia trait. Her husband had thalassemia trait. They both knew about that before they got married. It was an arranged marriage, and they're both practicing Muslims, but they have always been very practical about thalassemia. They had 2 children and had prenatal diagnosis for both pregnancies. They didn't have pre-implantation genetic diagnosis, and both those children were thalassemia trait. For the 3rd pregnancy, they were trying to save up because they've got 2 healthy children. They don't qualify for pre-implantation genetic diagnosis under the NHS, and so they were saving up to have PIGD, but surprise, they fell pregnant before that could be arranged. And so she decided she's going to have pre-implantation, you know, her PGD like she had done for the previous 2 pregnancies. But this time the child was affected and did have a high likelihood of having transfusion-dependent thalassemia. So this girl has seen what it's been like with her brother, seen him having to come to hospital twice every 3 weeks, seen the impact on his health of him taking and not taking his medications, and also the effect that's had on her, you know, with us randomly phoning her up and saying, you know, he hasn't turned up again, where is he, you know, trying to help her to hunt him down. So she was conflicted about it. You know, she's got 2 children with trait, but we wanted to help her to make an informed decision. Okay, so what we ended up doing, and her husband was, I have to say, extremely supportive, as was what was nice was the whole family was supportive of her, including my patient. And so we introduced her to one of our specialist nurses who looks after the children, who went through, you know, took a lot of time with her, went through what current management of children with thalassemia are, because her brother's in his 30s now. Things have changed and things have definitely improved. We introduced her to some another mum, just put them in phone contact so that she could talk to someone who has the child with thalassemia, you know, in a peer support way, and also put her in touch with the UK Thalassemia Society to again, so she could have like a rounded, informed decision about what she wanted to do. And in the end, decided to keep the baby. We did go through discussion around termination. It was early on because she'd presented early, Joyce, for her testing, because she was aware. She was on it. So even though she was a practicing Muslim, it was still early enough where she could have terminated the pregnancy and been consistent with her belief system. But it was interesting, and I spoke to her because I knew her well. My other specialist, the adult specialist nurse, spoke to her, and and baby's doing very well. Not such a baby now, must be 2, and he's doing very well with transfusion, and will probably start, if not hasn't started collation yet, will do in the next few months. And hopefully potentially will have the benefit of curative therapy. If one of its siblings is a bone marrow match, then could have a curative transplant, or potentially in the future other therapy treatments like gene therapy, etc. But it was a different case, but still sort of some complex issues.
It is. I mean, I think living in a family where you have a sibling who has an inherited condition, there's so many complexities to those homes that people parent differently when your child has an inherited condition, because there's a sense of blame within the parents about it. And then the stigma, when it comes to sickle, stigma is a huge thing. How much is stigma an issue in the Thal communities?
So it's different. So I think historically with the my older Cypriot patients, they were put in, because they were expected to die. So they didn't really even get options for education. They were put in like special schools, and no one really they didn't really have the same opportunities. Then I think, particularly in Cyprus, they passed a law where everyone had to know their thalassemia status before they could get married. So you went to the priest without your thalassemia status, you weren't getting married, and that had a massive impact on thalassemia births in Cyprus, like massive. Population's changed now. My younger patients and this family are from the Indian subcontinent, and then I think there is definitely a stigma, especially with arranged marriages. It's bad blood. You're going to have a sick child. You're not healthy. Especially depending on how well they've been transfused or collated previously. The patients can be small. They may need help to go through puberty, or have to have fertility treatment. Boys and girls, this impacts on, and the stigma affects the guys as much as the girls in thalassemia. And so it can be quite difficult. And I know I've had a lot of conversations with patients about going into an arranged marriage, and their parents saying you shouldn't tell them about your status, but they need to, because it's like a massive part of their lives. And I always say to my sickle and my thalassemia patients, you're starting a new relationship, you bring that boy or girl, man or woman, to the clinic. They need to be judged by the clinic aunties. I was like, you think your family are bad, nothing of badness still, because I think it's important. It's a massive part of their lives. They need to understand it, that it's part of that person. It's not a bad part, it's just part of them. And if they don't appreciate it and understand it and care about it, they're not going to be a good partner.
That's true. Thank you. I think that we could probably stop there.
Wow.
Soon.
Yes.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.